Hi, I'm Stephen Bruce. I run the Academy of Physical Medicine, and here's 45 minutes of free CPD for you. This is just an example of what we do. We run a free session every month, along with 70 plus hours of live learning with others CPD every year. If you'd like to see more, click the link in the info section below the video, and that'll take you through to our website. Enjoy. Hello again, and welcome to another of our lunchtime learning sessions, 45 minutes of great CPD. And today I have Pippa Cossens with me to talk about dealing with chronic pain. Now, if you've been with us for a while, you'll probably have seen Pippa before. She's been a virtual member of one of our shows, but she's participated in a number of case-based discussions as well. And she's also a real regular on the chat lines when she's not in the studio. She's been in practice as an osteopath for almost 30 years, and she's also a SIRPA practitioner. In fact, she's a member of the board at SIRPA. And we've done a show on SIRPA before with Georgie Oldfield, who founded it here in the UK. So if you missed it the first time round, you can look for that one in our archives, and it's well worth the look. SIRPA stands for the Stress Illness Recovery Practitioners Association. But I'm not sure whether that's relevant to what we're talking about today. So Pippa, thank you for coming in.
Thank you very much.
What have you got for us?
Well, I wanted to talk to you today about Change Your Pain, and Change Your Pain is something that we've developed at Osteopathy For All for our chronic pain patients.
Right, okay, so Osteopathy For All is
our clinic in East Sussex.
Yep, okay, and Change Your Pain is the name of the...
Is the sort of the name of the programme that sits within that.
Yeah. And I promised everybody you'd have a great new resource for them to look at, so
absolutely,
and this is it.
Absolutely.
Right.
And what it started with, interesting enough, was it started as part of the Osteopathy For All website, and it started as what we call our toolkits.
Yeah.
And so we specialise in treating patients with chronic pain and stress illness. And when we talk about stress illness, we're talking about things like fatigue, possibly migraine, irritable bowel syndrome, so a whole host of other things that often accompany chronic pain. So we actually almost put them under the same umbrella. We really just separate them for patients. But
when you say stress illness, you're not thinking about things like PTSD, the psychologically induced problems.
Well, we are. We're going into that bracket, definitely. But what we don't do, certainly as SIRPA practitioners or SIRPA trained practitioners, is we wouldn't go beyond the psychological. We're not going to go into any sort of psychiatric. So if our patients are under sort of psychiatric care, then actually that is something that is beyond our scope of practice.
I always struggle with that differentiation there, beyond the psychological. So knowing that there's a psychological component to what's going on as opposed to the psychological, psychotherapeutic.
Well, I think
resources.
we go quite a long way into that, but as I say, when somebody is experiencing sort of a personality disorder or more psychosis and things like that, that is definitely well outside of our remit. Okay. So we are tending to, and also what we will do is if we are concerned that somebody is, I would say that there are quite a number of SIRPA practitioners who are actually psychologically trained. They might be psychotherapists. And as osteopaths, as physical therapists, we feel we can't almost go as far as they can go. So what we would then do is if we had a patient, we thought, actually, I'm not comfortable that this patient's anxiety is not too much, then, or that they have got PTSD and it's not well controlled, then actually we would then refer them on, because there's a big line of safety, and we tend to err on the safe side of it. I
don't want to go over the stuff that we covered when we had Georgie Oldfield in the studio for this. I can't remember if it was virtual or live, but Georgie herself, is she a physiotherapist?
She is.
Right, and so the membership of SIRPA includes physios, osteos, chiros, and any other healthcare practitioner?
Yes, essentially you have to be a healthcare practitioner that is registered with a professional body. Right. So essentially, yes, it's not for just everybody, but you do have to have a professional recognised health qualification, so that you are covered by obviously your insurance, and that you have that that level of care and understanding.
Right. So tell us a bit more about Change for Pain then.
Yeah.
Change Your Pain, I beg your pardon.
Yeah, so Change Your Pain, as I say, we started as SIRPA practitioners working and integrating this within our osteopathic practice in East Sussex. And what we were finding is not only are we doing the physical aspect of the treatment, but we were finding at the end of the day that we were giving our patients maybe meditations to do, or we were talking to them about journaling, or we were saying actually, visualization technique. And what happened at the end of the day, you were sitting there thinking, oh my God, I've got to email so-and-so with all these links. So what we did was we created the toolkits on the Osteopathy For All website. And then what grew out of that is actually there's so much information, we couldn't put it just in that forum. And so essentially, Change Your Pain was born from there. And it is more than just resources. So essentially, it's a membership platform. And what it has in it is a huge number of, it does have a huge number of resources. I think there's at least 130 pieces of resources that are static in the site as it is, and we add to those every week. But it also is about community. It's about supporting those people as well. And so we do live classes, and we have, people can ask questions anytime they like. So we're trying to support them more from that point of view. So as I say, it's grown from a sort of, you don't have to, I think because chronic pain is so individual, and the recovery from chronic pain is so individual, people need different resources. It's not all the same for every single person. And so what we're trying to do is bring all of that to individuals who are experiencing chronic pain.
We've actually had a question from Biljana. It's just come in. Unusual name, Biljana. So I'm assuming, Biljana, you're the same lady who came on Laurie Hartman's course recently. And great to have you on the show. She says, the question is, assuming the disorder is already diagnosed, but what about if it's not?
No, yes, now that's a really good point. So when we're talking about chronic pain, we are tending to put that in its classified bracket of pain that's been there for more than 3 months. But very interestingly enough, we find in practice that we're identifying these patients much, much earlier because of our knowledge. So we changed the way we take our case history to include more questions to make sure that we're identifying these chronic pain patients. But for like you say, classically for a chronic pain patient, what we're looking at is patients who've had pain for more than 3 months, but have also had other diagnoses ruled out. Right. So of course we're not looking at any patients that have got fracture. We're not looking at any patients with infection, cauda-equina syndrome, or any sort of pathology that needs to be ruled out. So we're very careful that actually people who either join the program or are seeing us in practice have had those things done. But so many patients come to us and they've been in pain for 10 years and they've seen everybody and everything has been ruled out, and they're then left with not very much support. And so this is where this comes in.
I wonder whether Biljana was asking about the psychological or psychological disorders.
Okay, yes.
Because obviously if they haven't been diagnosed, then you don't know that you're straying to that territory. But then that could be the same for all practice, couldn't it?
Yeah, absolutely. And I think we're on the lookout for it too, because we're looking, when we ask more psychological type questions, and that's why I wouldn't ever recommend that people don't do it without some sort of backing, some sort of training, because actually you can by asking a question, perhaps we ask very gently about, was there anything as far back as your childhood that might have meant that your nervous system had become agitated? And you're straying into territory that might bring things up. So if that, as I say, if that brings something up that we are right on it with regards to, trying to get them the help that they need by referring them on to the GP or a psychological therapist.
Okay. How would I or one of our chiropractor members or anyone else, how would they make use of this?
So essentially, we've built it for the patients, but and the patients that often this is suitable for are those slight heart sink patients, those ones that you've been seeing for a long time and they don't change, or they change for 3 days after treatment and then they come back. The ones who, they can be quite, their life is hard for them, they're struggling, if that makes sense, and they bring quite a lot of that to the appointment.
Fibromyalgia patients.
Absolutely. And
which I mentioned for a reason.
Yes, absolutely.
You better tell them what the reason is.
I'm going to tell them what the reason is, yeah. So I myself had a diagnosis of fibromyalgia. I was diagnosed in 2017, having been in pain since 2013. And in 2017, I was at the point that I couldn't even walk my Labradors around the block. I was having to pay somebody to walk my Labradors around the block. I was a single parent. I was just about managing to get off my sofa to go to work because I needed to provide a roof over my head and food on our table. And I didn't know that this was going to change. And even having been an osteopath for a good number of years at that point, did not know about this area of the work. And I then discovered SIRPA. And for me, the SIRPA conference 5 years ago was absolutely life-changing. Suddenly I was in a room with medics from the UK and the States who actually understood it. They got the neuroscience, they understood all aspects of it, but not only that, they had the answer. They knew how to fix it. And so from 5 years ago to now, I'm not sure that you're aware, but this summer actually, to raise awareness for chronic pain recovery, I drove from Land's End to John O'Groats, and on the way back down I climbed Ben Nevis, Scarfell Pike and Snowdon. Now again, 5 years ago I didn't know if I was going to be able to get off my sofa. This summer, actually at the top of Ben Nevis, having had the most amazing anxiety attack on the way up, actually I felt like I'd really achieved. And so when I bring this to people, it's like, actually I bring this not only from a point of view of experience and the neuroscience, but of lived experience. And that's why I'm so passionate about it.
Yeah, I can imagine that. And as you said, if you've been through it yourself and you've seen some results, then it would make me quite passionate about this as well.
Yeah.
But I'm still curious to know how I make use of this as an osteopath, because my patients aren't your patients.
No.
So what?
Yeah, absolutely.
Or any of our other members.
Yeah.
Of course, yeah.
So I think the thing with that, and it feels like a slightly. I feel like it's a slightly dodgy ground. I don't want to tread on other people's practices, but essentially there will be people who love treating sports people and do not want to treat chronic pain. Those are some people that we might be able to help. But what I hope ongoing is that actually, even if you are treating chronic pain, but you perhaps are not SIRPA trained and you don't have more psychological sort of understanding of it, is that we can work alongside your hands-on treatment, because there are osteopaths around the country doing absolutely fantastic work, and I think they're getting chronic pain patients better without this knowledge, because they are brilliant with their hands on, they're listening with their hands, they are understanding the patient, they are hearing the patient, they are there for the patient, and I think that's why we do so brilliantly.
Don't forget the chiropractors and physios
sorry,
as well.
I'm so sorry. I'm so sorry. Yes, I know. I always describe myself as an osteopath. I'm like a stick of rock. If you break me in half, I say osteopath the whole way through. So I do apologise to the other professions. But essentially, yeah, this is about supporting them. So if you don't want to do all the talking, if you don't want to do all the information, if you don't want to do all the searching for meditations and breath work and all that sort of stuff, that's what's in the programme. That's what's in the modules, alongside live classes, so that essentially we are doing that part of the support while you carry on doing the absolutely fabulous hands-on stuff. And when you start to, and we're also happy to help support practitioners, so that actually if they're kind of going, oh, I think this might be a patient of that is in that category, how do I identify them? Then we're happy to help with that. And then maybe work in partnership. But as I say, this is something that the patients can turn up to. They've got a whole, the modules at the beginning, we recommend that they work through in order, because it's about that pain understanding journey. And then we talk about, what's in your backpack. And that's like, everything that's happened to you in your story is in your backpack. And then what we do through live classes.
We've got a slide of that, haven't we? So somewhere along the line, and my little clicker, there we go. No, Justin will have to move the slides forward for us because the clicker's not working.
They're perfect.
Right, so there we go. What's in the chronic pain backpack?
So what's in your chronic pain backpack is anything that has influenced you possibly adversely. That sounds a bit, but anything that has overwhelmed your nervous system at any point through your lifetime, really. Now that might be that actually you had an accident and you broke your leg, and actually your leg has healed, but you've still got pain 6 years later, and that might be because actually the scenario when you broke your leg was very overwhelming to your nervous system. It wasn't just about breaking your leg and getting better, it's about the fact that you were worried you were going to lose your job, or you lost your house, or actually you had nobody to look after you. And when it overwhelms our nervous system, that's the important bit, if that makes sense. So it can be on any number of levels. And so essentially what we're trying to do is then help people unpick that, identify, there are worksheets in the module that help people identify what are important in their story, and then we then help with the resources as to how to unpick that. But we also do every 2 weeks we have a live class, so people can come and we pick a topic and we ask the membership what they'd like, what they're interested in, what they're struggling with, and we then produce a live class that they have a Q&A at the end of to help unpick that for them.
Okay, so what we've got on the screen here looks to me as though actually it's meant to be a paper, it would ideally be a paper handout, and we fill in those boxes over there with the stuff relating to the...
Yes, that's sort of the idea of what might be those things that sit in those categories, and this is what relevant to what's happened to you. Funnily enough, actually the worksheet has a third page that doesn't have the categories, so that you can actually then say, actually this is what's stressful for me. Yeah.
Interesting. I looked at family and I was thinking family as a support mechanism, but actually in here you've got, are you caring for elderly patients, which is obviously that's a real stress and a bit of a strain on your system, isn't it?
And it can be too, like you say, you could be you could have elderly parents who are not terribly difficult, but you've also got school-age children.
Yeah.
And you might be the jam in that sandwich, and actually then you're being pulled from both sides. And then again, then we start to see a little bit of fatigue, and then we start to see a little bit of overwhelm.
Yeah, and of course my favourite there, PTSD, has come up under previous trauma. Under stress, you've got toxic stress. Is that as self-explanatory as it sounds? Are we talking drug-induced stress, or is that something different?
No, interesting enough, I would say more interestingly, relationship stress.
Right.
If you're in a very toxic relationship
Okay.
issue, that's often something that can be quite important.
Yeah. So I'm going to come back to my, I've got loads of questions I could address as well. I'm going to come back to my earlier question. I've got a patient who I think is a candidate for being handled in this way. How do I physically get them to you, to your backpack here, to get this all out to them? Do I simply email them your details and say, go and talk to Pippa, because that would do far better than talking to me?
Well, interesting enough, what we've got, obviously the patient can come straight to the Change Your Pain site, or we've actually set up an affiliate program, because we want to do this and help people, and we also want to be appreciative of the people who do send people to the program. So all you need to do, actually, we have a link, or if you email us, we can send you the information.
Okay.
And essentially what that does is you then sign up as an affiliate, and actually that would mean that you get a financial reward for that, every person that signs up, but also actually we can then support you in that. Actually, you might want to email us and say, oh God, do you think Doris needs this? And we want to I want to bring this to the professions, because essentially it's life-changing. It's changed our practice enormously. Not just the program, but the knowledge has changed the way we practice. And I mean, when you see the light bulb come on in those patients' eyes of like, oh my God, somebody who gets this, somebody who knows how to fix it, it's enormous. Now, we do talk about recovery. That is not true for all patients. So if you have an underlying condition, like an autoimmune condition, we're not going to change the autoimmune aspect of that disease. However, pain comes with a lot of these conditions, and pain can be changed. So if you have, often people who have pain alongside these things actually have better days and worse days. So what we would do is we can say, okay, so if we can get you to your better days, then that's great. And for some people, we know that we can, if there's no underlying condition, there's a good chance that we can get them to recovery. Now, I, in my own pain journey, wouldn't say I'm 100%. I would say that I am always going to have to work at it slightly. But as I say, the evidence speaks for itself, climbing these mountains this summer.
Yeah, indeed. Question came in from Ian earlier on. He said, is the training available online for practitioners? I think he's talking about SIRPA training.
Yes.
Because that's when the question came in.
Yeah.
And maybe I should just suggest that he looks back at the interview I did with Georgie Oldfield on SIRPA.
Definitely.
Or alternatively, go to the SIRPA website, SIRPA and
.org.
And see what you just put that into Google and it comes up as a
Absolutely, and I think they are just about to take a group intake of practitioner training. It's an online training. It's excellent, and there's an amazing support community there too, actually.
Yeah.
So it's it was life-changing and practice changing for us.
Yeah. Bob has asked, if we suspect an undiagnosed mental health issue, who should we refer them to? I know a couple of good hypnotherapists that I've referred to in the past, but is there a recommended central body that we can use?
I would go back to the GP at that point if you were concerned.
Yeah, it does strike me that if you think there's an undiagnosed mental health issue, they need to go to someone who can diagnose that mental health problem.
Yeah.
And I don't know that hypnotherapists are the right people to diagnose. They might be the right remedy or the right course for help. But yeah, GP, I suppose.
Yes.
I suspect whenever you say go and make an appointment with your GP, people's hearts sink these days, given the waiting lists and so on. But hopefully that helps. Bob.
Yeah.
Emily says, would this work for MS patients?
So MS is, again, we're in a different situation because we've got changes within the tissue. So again, you may find that actually it would help with any pain that they were experiencing, but it's not going to kind of make them better. Now, what it does do, so it's not just about the pain, it is about kind of helping the fatigue, helping sleep. It is about health, so it's not just about that. So essentially it does build in that way, but no,
Which sounds better to me.
Yeah.
So we are making them better, we're just not curing their underlying problem.
No, although, as I say, and I still think you've got to be cure is such a big word, and I mean, even for myself, I got into a little bit of a tit-for-tat conversation with somebody on Facebook the other day saying, oh, well, you can't have had fibromyalgia, it must have been the wrong diagnosis because you're better. It's like, actually the evidence, and there's been 4 amazing studies this year about this approach, the SIRPA type approach, and it is getting people better. And I think we do need to talk about recovery, because actually otherwise we're stopping people getting better by not using that language. But we've got to work with them, but we've also got to not frighten them, and that is a really big passion of mine. It's like, we can't say, oh, that thing where you have a patient who comes in. I had one who'd been in, I can't remember, 25 years ago, she'd been told that she'd got back pain, it might be a cauda equina. She'd been given a card to put in her wallet to carry around with her, and she came in to see me and I've got back pain, and she said, it might be this. And we went through it and we talked through it, and I said, well, you haven't got any of the signs and symptoms, it's not getting worse and whatever, and we talked about it. And I said, to be honest, I've been in practice nearly 30 years and I've never seen one.
Who gave her the card?
I'm not sure whether that was somebody at the hospital or somebody at her GP.
Because we've done quite a few shows on cauda equina syndrome, and I'm just thinking, I'm utterly horrified. If someone thinks it might be cauda equina, they've said, well, just give people this card if you get pain. Well, she'd be bloody well investigated immediately.
Well, I think she'd probably been investigated, then told that actually if she had these symptoms come back and they were on the ones that were on the card, then she needed to get to hospital immediately, because otherwise, she was going to lose control of her bladder and her bowel and all this sort of stuff. Absolutely terrifying. We had one conversation, one hands-on treatment, and her sort of 20 odd years of back pain disappeared overnight.
Yeah.
Now, okay, we don't get them all like that, but if we can take the fear out, then we make an enormous difference. And that's why, as therapists, we have to be so careful about our language with our patients.
Yeah, of course. Jono has said, how well have you seen this approach work with people with CRPS?
Now, I haven't treated a huge number of people with CRPS, but there are people working in the field with it. There's I think he's a physiotherapist called Tim Beams.
Yes,
he's based out of Kent. He's working with a similar approach from NOI.
I've been on the show.
Oh, brilliant. So the Neuroorthopedic Institute. And that is certainly an area of specialisation that he has. So again, I think we've had one patient in the practice with it. And again, it does make whether the patient kind of embraces the programme. Sometimes we don't get anywhere because people are not ready. You have to meet people where they're at. But what we're trying to do is provide them with the information so that they can take the choice to take that journey or not.
Yeah. I guess I haven't seen any others come in at the moment, but we could just spend our time going through every possible chronic pain condition or label and saying, do you have a favourite sort of person, a patient or condition for this approach? Who responds best?
Who responds best? I don't know. Actually, that is a good question. I think. Oh, that is a really good question. I think interesting.
I'm feeling very flattered.
Yeah, I think interesting enough, where I benefit is obviously having had a fibro diagnosis and having recovered. The fibro patients like that because essentially they've already got hope. They've got hope when they come through the door, and hope is something that's really important. The ones, I suppose it's not necessarily a type of patient, it's when somebody, I love it when somebody sees the connection between the fact that their physical symptoms came on at the same time as an emotional event, or there was loads of emotion going on when they had the injury originally. And as I say, when they start to see that, that is an amazing thing. So no, I'm happy with all of them. And as I say, it's those slight heart sink patients are my absolute favourites,
Yeah. Well, I guess for a lot of them, they've been through so many practitioners that anything that offers hope is going to be good, and therefore you're starting from such a low level, you can only make a positive difference out of them.
Yes.
Rebecca has said she's had 2 patients, one diagnosed with TMS and the other with FND.
Yep.
Both disorders I wasn't familiar with. I did refer the TMS to a SIRPA trained practitioner. The person with FND was on the waiting list for a neurologist who specialised. And that's all Rebecca has said, so I don't know what the outcome was for that.
No, so TMS is what Dr. John Sarno, who really kind of pioneered this work in the States, that's what he called kind of his chronic pain patients, and it stands for tension myoneural syndrome. And
I'm glad you told me that. I think it was temporomandibular.
No, funny enough, TMJ is another factor often in these chronic pain pictures.
Yeah.
But so TMS, and for me, with a hands-on perspective and how that reflects within the patient, is the patient often has an increased level of muscular tension often throughout the body, but it can be in certain areas. But it's almost like somebody's dialed up. It's like they've dialed up the level of tension. It's not kind of, I'm not sure you'd say it's hypertonic, it's not necessarily in spasm, but it's like they are the patients that feel like rocks, and they just feel like that all the time. And so that is then about that neurological feedback, and the thing that's sourcing into that is the emotions, the fear, and everything that we need to then change, or the sensitivity within the nervous system that we need to change. The trouble is with it, and we had this conversation at a meeting at the SIRPA, before the SIRPA conference last weekend, is we don't have a good name for all of these conditions. You know, even in the room of us who all agree on this approach, we couldn't come up with a name of what we'd call an organisation. You know, the chronic pain recovery, or the TMS society, the mind-body syndrome, neural circuit pain. And again, functional neurological disorder does come under that bracket. You know, patients in that bracket can be having enormous neurological signs and symptoms of, you know, look like they've had stroke and they can't walk and things. And actually there is a case for this approach, you know, for that.
Yeah, we were talking about FND only the other day, and I've completely forgotten the context of it now. But it was the first time I'd come across that abbreviation. So we had a fantastic speaker at the SIRPA conference last weekend called Leo Russell, who's actually a clinical psychologist working out of Exeter, you know, with chronic pain. My team will be writing this down in the background. Right, next speaker.
No, brilliant speaker actually, brilliant speaker, and he was talking about how they're bringing that sort of mind-body biopsychosocial approach to it.
Yeah, and I suppose, are we just here simply talking about a focused approach to the biopsychosocial model?
I think it's implementing it. I think we talk about it like we're doing it, and actually I'm not sure we are doing it. You know, I think, again, as osteopaths and physios and chiropractors, we are very good at kind of saying, actually, have you tried this? Would you like to do that as well? That sort of self-care element or exercise element. This is very specific, though. This is much more down to, we will look at emotions. We do look at timelines. You know, some of the worksheets that we have is looking at people's timelines, and actually things like adverse childhood experiences, what has happened to people in their very, very early life, can set up a chronic pain pattern in their adult life. And if we don't ask about it, we don't know that it's there. And then patients kind of, they go, well, I've tried this and I've tried that and I've tried the other. It's like, well, unless we understand and recognise why it's there, then we can't fix it. And I think some people get lucky, and some people, but then they're often, like you say, chronic pain patients often have gone from pillar to post, and they might have a new therapist and that works brilliantly for them for a while, and then they move on to somebody else and they move on to somebody else. This is actually kind of putting all of that together, I think.
We had a lovely lady a week or so ago, Gillian Van Heegen, a medical consultant. She was talking about psychosexual therapy. I don't know if you watched that show.
I didn't actually, that one, no.
But it was interesting because a lot of it was about adverse previous experiences, in her case in a sexual context. But I guess that all overlaps with what you're doing, because it's all a component potentially in chronic pain.
Absolutely, and often again, you do have a light bulb moment when a patient kind of, you say, you know, was there anything, I mean, in the SIRPA questionnaire that we send out when we see patients, actually there's quite a lot of questions about that, but in our case history and practice, what we tend to ask is, you know, was there anything that was upsetting or stressful within your childhood? And it's so, how many, it doesn't have to be outside the realms of normal that, you know, mum and dad fought all the time, and actually then dad left and then mum got depressed. It's not, you know, that's not that, you know, and suddenly actually then what happens is that young person then feels that they've got to behave, or that because mum's not very well, or it could be dad, whichever, they've got to then step up, and they've then then we start getting personality traits of people pleasing and perfectionism. And again, what's that doing to the nervous system? It's like people who are on high alert, people who are like, you know, they're packing for a day out and they've got the sun cream and the snow shovel because they've got to make sure that everything's going to be all right for everybody. And that state in the nervous system is then going to be a precursor to chronic pain when they get to the point where their systems go, no, I can't do this anymore. And the body goes, all right, well, I'm going to produce pain so that you don't go out anymore, because essentially it's too much.
Yeah. We've a few other questions here. Ian has asked whether the pack includes nutritional advice. Now, I'm not sure whether he's talking about this or whether he's talking about SIRPA more generally. So
SIRPA generally doesn't cover any nutritional advice. We actually do cover a little bit of nutritional information. I caveat that with the fact that I am not a nutritionist, but I've spoken to nutritionists, and again, it's what I've found helpful. So we do have some stuff on we have a module called the Pain-Free Lifestyle, and in the Pain-Free Lifestyle, it's all about nutrition, diet, exercise or getting moving safely and within your, within that range, sleep. So we do cover that certainly. And I think when we talk about pain management and recovery, people have got to manage it on their way to recovery. So, a lot of the techniques are in there. And diet, I think, is important. But I think, again, we have to take the stress out of diet. How often people go, well, I don't eat this and I don't eat that and I don't eat the other and I don't. It's like, okay, what's that doing to your nervous system? It's making you so stressed that actually that becomes more of a problem than a resource.
Yeah, the stress I would have thought is more from, oh my God, I've got to have a meal and I mustn't eat that or that or that. So trying to put together a week's program of meals is difficult and so on.
And also they're tired, and so therefore also then they don't want to eat well or can't find it very difficult to produce healthy food. So part of the thing in that module, for instance, is we've produced menu plans. So essentially there's a one that you can look at and work off, vegetarian or not, and there's also a blank one so that you can write your own. Just that and talking to people about keeping their blood sugar levels stable. So again, that they don't get massive rises in insulin or cortisol, because of course that's just going to stress the system more.
You mentioned that you're not a nutritional expert, and some of this is based on your own experience. And this is not meant to sound critical, because I'm all over the idea that nutrition plays a big role, big part in recovery and so on. But I do think that there is a danger that, we put in our own beliefs, which we shouldn't do according to the practice standards and so on, into what we tell patients. Now, I can remember ages and ages ago somebody saying when I was in training, tomatoes are an inflammatory food and you mustn't eat tomatoes. Well, I've never found a blind bit of difference between eating tomatoes and not eating tomatoes. And I wonder, is your nutritional advice just your experience, or is it something which you can put evidence behind? And you talked about evidence earlier on.
Yeah, no, we definitely can put evidence behind it. And also, if anybody's got any queries or whatever, we would recommend that they see a nutritional therapist. But a lot of it is about, a lot of it's about taking the stress out of it, if that makes sense. So it's not, I'm not saying, oh, you must or mustn't eat this. In fact, I'm almost saying to people, maybe don't do that. Of course, if you've got, you're allergic to something, don't eat it. And of course, if you've got an intolerance, then actually, but if you want to go out and have a piece of cake with your friend on a Friday, and that actually makes you feel well, but don't eat cake the rest of the week. It's really, but a lot of what we put in is less general than that. Is evidence-based.
I can think back to my own experience of this. So I had a patient when I was relatively newly qualified, and a patient came to me and she wanted some advice on losing weight. And so I said, right, what we're going to do is, on the basis of my absolutely bugger all knowledge of nutrition, I didn't even nutrition was even invented then, it was. But I said, we're going to keep a food diary, and I need to know how many calories you've been consuming, which I now realise is nonsense anyway. But of course, she said, no, I can't do that. I mean, I've eaten a bit of a shepherd's pie. How do I know how many calories there are in a bit of a shepherd's pie or whatever else? And of course, that stress is on the patient who's trying to manage their weight all the time. I just don't know what this is. So, as you say, I think giving them the tools to help them do that must relieve the stress.
And it's more lifestyle advice almost in that respect. We talk about putting all your meals in freezer bags and freezing them and then putting them in the slow cooker on the day that you need it, just to make it easy. Yeah.
More questions. Karina says, how is SIRPA different from ACT, acceptance and commitment therapy? The big difference is the acceptance that you're going to be in pain for the whole time, that you can't get better, and the difference is that SIRPA, that we believe that actually people can, and there is evidence to show that people can recover. Who's responsible for the evidence? Who's done this?
So there's a huge catalogue of evidence. A lot of it has come out of the States. There's an organisation in the States called the PPDA, which is the Psychophysiologic Disorder Association. I nearly put an extra P in there. And they actually have a huge amount of evidence. And then again, this last year, there's been, I think, 4 studies, one of which is the Boulder study, showing that the approach that we use, which is again similar to some of the things in the acceptance and commitment therapy, in the sense that we do want to calm the system down, we want to make it feel better, all of those things, but actually giving people the evidence and the knowledge and the hope that they can recover actually makes a huge deal of difference.
You've probably spent some time looking at this, but what's the quality of the evidence? Because so much evidence, so much stuff one reads in medical journals and so on, when you look deeply into it, you find is biased, distorted, or sometimes just outright fibs.
Yeah, no, the Boulder study, certainly, I can't quote you the figures without looking at it, but is a really good study. And I think they split it into 3 cohorts. So they had, I can't remember what the kind of the control cohort, what they did or didn't do with them. To be absolutely honest, I can't remember. But the second cohort, they did like a CBT. And then the third one was this approach where they look at the sort of the emotional awareness and the understanding, which is, emotional awareness and acceptance therapy. So that definitely, that cohort had a 66% recovery rate.
Right. And Boulder is spelled how?
Boulder, and it's Boulder, Colorado. So it was done in Boulder, so hence the Boulder study. And
I assumed it was going to be an acronym for something.
No,
Someone
no,
spent a month inventing.
Yes, the bonkers or something. Yeah. No, so that was done by Tor Wager and Yoni Ashen and Howard Schuberner.
Okay. I will try to find that and send it out in my afternoon email so that people, if they want to, they can
no, it's definitely
form their own opinion.
It is. I mean, again, it's not thousands and thousands and thousands of people, but it's a good study.
Yeah. Okay.
So.
What else have we got in here? Mayuri says, do patients who have long COVID start to feel they're more sensitive to pain? She's had 2 patients who've had to leave work as a result of intolerance to pain. Low immune system might be contributory, she says. Now,
definitely, and in fact, at the SIRPA conference on Saturday, we were talking about long COVID a little bit, and there's a huge number of crossovers within the cohorts. So often, you've got the fatigue and the pain and perhaps, as I say, irritable bowel reflux, whatever the other symptoms are. And it is very much there. Something has probably happened to sensitize their system. And then what it does is it becomes hypersensitive to pain. It becomes much more reactive to pain.
Right. Okay. Simon says, how do you get someone who owns their pain to acknowledge that a change is needed? Owns was in...
Yeah, that's a good question.
Inverted commas.
The hardest thing I think about this work is almost getting people to believe that it can change. And I think it's like being on the front end of a wave. It is quite hard work, and it is almost about trying to get people to change their belief. Now, the belief is backed up by science, but our biomedical belief is so entrenched. And until they're kind of teaching this approach at medical school, we're going to be fighting that. But some people you just have to give up with. Absolutely, absolutely categorically, it's almost not worth your energy.
Yes.
And it makes me sad. Actually, it makes me sad and frustrated because there are people we could help, and they won't. They need their pain at that point. They don't want to change their pain. They identify with their pain. Their pain is keeping them safe. Perceiving to keep them safe. Their pain is stopping them from having to step out.
Then why do they come to you?
Do you know, that's a really interesting question. I sometimes think it's because, I've tried everything, so then I can be seen to have tried.
Oh, okay.
So there is an element of that in there, but I mean, we obviously, because we have quite a lot of patients who come to us just for osteopathy, but they come with pain for another reason. They don't think that they've got chronic pain necessarily.
Yes.
They haven't got a diagnosis. It's interesting that we're seeing it much earlier before they've kind of really got hold of the label.
Yeah. Well, here's something else interesting for you then. We are, actually it's me, not anybody else, but we're in sort of discussions with somebody whose specialist subject, for want of a better expression, is encouraging behaviour change. And she's a PhD academic at her university. And I'm really hoping she'll come on the show, not least because she has the wonderful name of Angel, which I think is great. But that might be something that people could use in conjunction with this, couldn't they?
Yeah.
To take those patients who are influenceable and use better methods to encourage change in their behaviour.
Well, that's what a lot of what we're doing, and that's a lot of what this works. And I think that's why the live classes work really well, because essentially people can then ask that question relevant to their story. Rather than just giving them the information, it's about then supporting and nurturing them along that journey.
Yeah.
So.
Okay, we're going to have to run through these quite quickly now. Sharon says she didn't catch the name of the expert based in Exeter that you mentioned.
Leo Russell.
Leo Russell. We might be hearing more of him because we'll probably approach him and say, come on the show. Simon says, could this all be related or overlapped with sympathetic overstimulation?
Absolutely.
It says simulation on here, but I think that's a typo.
Yeah, absolutely.
Yeah. And Salome Olivia says, some patients with chronic pain feel unable to move from the pharmacological management to less pills. How do you approach that?
That's a really interesting one. I think you have to be very careful with that, because essentially, you know, there's this whole thing about opioids, and actually, you know, people shouldn't be on them, and it's not like, oh my God, we're going to drop you off them. Yeah. Dr. Sarno, interestingly enough, back in the 80s, kind of like, well, don't go to the physical therapist, don't take your medication. It's like, whoa, no, let's not do that. So you're going to have to work within that to start with, and you've got to get the patient to a point at which they feel safe and stable enough to be able to then drop their medication in alignment with their medical practitioner.
Yeah.
So, but there is a reliance, because that's their safety net.
Yes, yeah. Darcy says it's almost ubiquitous now, but the correct dose of CBD can be very beneficial for chronic pain syndromes. Do you use or recommend CBD, and probably we talk about cannabinoids?
Yeah,
not oil, or medicinal cannabis proper.
No, we don't. I don't have a particular opinion on it one way, but again, I'm trying to get people off having to take something to fix their pain. Again, there's a little bit, I'm not saying it's not helpful, and actually sometimes things that are helpful for patients so that their pain is less, so that they can do more of the work, is a good thing, but I'm trying to get people off stuff.
Yes. We had a lovely doctor on the show, a GP, a couple of years ago, I think, before COVID, and he was talking about the overprescription of all types of medication. But as you say, the opioids and so on have been shown to be so bad for people that we should be trying to get people off them.
No, definitely.
And I don't know enough about cannabis to know whether there are any problems associated with it, or any studies that have been done into the long-term effects of medicinal cannabis. Keith says, what backup is there if it goes wrong? If someone's under a psychologist on the NHS, there's a regular team meeting and OT, CBT, rehab, all kinds of teams involved. It takes a long time to get, but it's good when it begins. Privately, if someone has 3 sessions, decides it's too costly and goes away after a whole chapter of their childhood has been opened, where's the safety net for them?
I think that's an excellent question. We are just trying to provide that support for them. We always allow people to, or allow, that's the wrong word, we're always there for people to reach out, which makes it, we are working harder, but we will always try to find them.
You say allow, but actually quite often we have to tell patients that it's okay for them to call, don't we?
Yeah, you know what we do.
It's a bit like not inviting them back for a follow-up treatment.
Yeah.
If you don't tell them they can come back for a follow-up treatment, sometimes they think they've been sent away.
Yeah, no, absolutely. We're always like, just please emails. And again, what we would always then try to do is to find them a practitioner that they feel is often, you know, will support them ongoing. We don't want to leave them just blowing in the wind. We want to make sure that they go somewhere supportive.
Okay. Gary says, is SIRPA similar to the program used by Dr. Jonathan Kuttner, MD? He has a program called Life After Pain based on John Sarno's studies.
I don't know the work, but if it's based on Dr. John Sarno's work, then it is very similar.
Right, good. And PC, it says here, or Peggy, excuse me, says, do the medics recognise SIRPA?
So we're in an interesting place with that. Some of them do. And in fact, actually, I was talking to a GP who is SIRPA trained last weekend at the conference. And so there are a number of people who are but not necessarily recognised in that true sense of they don't know what it is, for a start.
But it won't be under any NHS guidelines,
no,
will it?
It won't.
Nice
and also,
guidelines.
She was so funny, the GP was saying that she'd actually had a formal complaint that had been taken forward against her because she'd asked too many questions. You know, the patient had come in, wanted something, you know, quick on a prescription probably, and she'd asked too many questions and actually had taken a formal complaint against the GP.
Good Lord.
I
hope it was unsuccessful.
I can't remember where she was at in the process with that, but the way there is so much. In fact, what the GPs were saying is that they're identifying a lot of functional illness within their GP surgeries, but they don't know what to do with it. And essentially, this approach is that thing where that's what takes the next step, but it's not recognised by the NHS, and it's not happening in a cohesive way necessarily from that. You know, from that point of view.
We're going to wind up with the quote here. The obviously very well-read Chris says, wasn't it Hippocrates who said, the one who takes medicine has to recover twice, once from the disease and once from the medicine? So
I love that.
Yeah, it is a nice quote, isn't it? You know, we've had 492 people watching, which is a good number. I said I was disappointed with 300 for the last broadcast, which wasn't about a medical subject, but most people will be jolly pleased with 300, but 500 is even better still. So clearly, well, chronic pain, you'd expect it to be really popular with our audience, wouldn't you? And 30 seconds, what do you want people to do now?
What I'd love for people to do now is if they want any more information, that they contact us, because we're really happy to answer any questions, give out more information. As I say, if you want details of the affiliate program, we're happy to do that. And our email is support@changeyourpain.co.uk, and we can answer anything from there. But yeah, I want to bring this work to more people, more practitioners support the patients, so just get in touch.
The more of that, the more evidence we get as well.
Absolutely.
Great. So
Absolutely.
support@changeyourpain.co.uk.
Yes.
Brilliant. Pippa, thank you very much. It's been great. It's been a treat as always.
Thank you.